Hello, good afternoon. I'd like to introduce you to Dr. Jenny Swann, a remarkable colleague from Sheffield. Jenny has spent 9 years working in the inner city of Sheffield in a practice where she had to deal with ethnic and cultural minorities and took a very keen interest in this. Prior to this, she'd worked in general practice, and subsequent to leaving that practice, she's continued to work in general practice. She's worked closely with patients from a variety and various different cultural backgrounds. I'd like to welcome you, Jenny, to Cork. So tough fáilte ród go dtí Coláiste na Hallscoile Cork. Welcome to University College Cork and to the School of Medicine in Cork.
Thank you very much, Pat.
Okay, Jenny, I'd like to ask you, first of all, if you tell us a little bit about the patients that you've seen in your practice in Mulberry.
In Mulberry. Well, they were the patients that were dispersed to Sheffield from the National Asylum Service. So Sheffield had people, had existing ethnic minority groups, and these people were dispersed to Sheffield according to their groups, but there are quite a lot of them. So we have Iranians and Iraqis, and Ethiopians and Eritreans, people from the Congo, people from Zimbabwe, and people from Sudan. But we also had other people on top of that. So that gives you a flavour of the types of nationalities who could come in through our door in any week, in any month, in any day.
So I guess many of these people would have been asylum seekers, not necessarily economic migrants as such.
They were all asylum seekers.
Okay.
All asylum seekers.
So I just wonder if you would talk about, because of what I have not been an asylum seeker myself, but I can kind of appreciate some of the challenges you might face as an asylum seeker, and the journeys that you have to take. So trust would be, I guess, a big issue for asylum seekers in trusting anybody, especially somebody in authority. So how did you manage to address that issue and establish trust, which is such an important issue in medical practice?
Well, we were lucky. The team was set up, the Mulberry team was set up especially as a specialised service for asylum seekers, because in the early sort of 2000s, when the immigration or migration problem with asylum seekers began to become acute, and Dover and the southeast of the country were complaining that they had all the burden of it, and then they began to disperse with a dispersal system to disperse asylum seekers through the country. Everybody suddenly, all the towns and cities of a certain size had to accommodate people that they weren't used to. So the Sheffield response to that was to set up a specialised system, specialised primary care centre for them. And the reason for that was because the GPs very quickly said we can't cope with the types of problems that they're bringing, with the multitude of languages that they're coming with. We can't manage this in our normal, ordinary practices. So Sheffield set up this dedicated primary care service. So it was central. It was run by nurse practitioners and triage. We had receptionists who were multilingual, again, from the community, because the people we were getting, there were people in the communities already. So from the beginning, we had the right ethos. So, but what ethos do you need? Well, the first and foremost, really, is you have to be non-judgmental. They had to be welcomed. They weren't welcomed anywhere else. They weren't welcomed in the communities, really. They weren't welcomed in Britain. At the time, the press was very anti-immigration. They're lumped together with economic migrants, and it's misunderstood that asylum seekers are a different group. So they had a lot of prejudice against them. They're coming into a lot of prejudice. So the first thing is you have to be non-judgmental, and that actually goes a long way. Then you get trust. If they see that they're accepted, then you gain their trust. So that was very important. The other thing was, because we were a dedicated service, everybody who worked there had the same values. So the teamwork was very strong. Fantastic team, really. And we had counsellors and interpreters, everybody who was there was interested in working with this group of people. So that was very helpful. When it comes to the doctoring, they're human. They respond, their distress is expressed in the way that human distress is expressed. And that doesn't need language to understand. You don't need to speak French or Eritrean. They don't speak Eritrean. They speak, can't remember the language, it's just gone out of my head. But you don't need to speak their language to see that they're distressed, to know that something dreadful has happened. And actually, the secret is good communication skills and use your humanity. And in preparation for this, I kind of realised that when you are dealing with people whose background contains unspeakable acts of inhumanity towards them, the remedy, the healing comes with using your humanity to heal them. They need compassion, they need kindness, they need you to listen, and they need their distress to be held until they can work through it. And that's what we did. And we do it very successfully, and they're still doing it. But I stepped out a couple of years ago, after 10 years. But yes, so the thing is, I don't think anybody should feel that you need special gifts to be able to communicate with a human being, a fellow human being. You need to have curiosity and empathy and respect. And you sit down with that, and it's there on the table, and that's what you give them. And everything flows from that, I would say.
I guess it might be relatively straightforward to have that empathy and respect within a culture that you're familiar with, but we do talk about patient-centred care, and Ian McWheeny from Canada mentioned that we have to learn to see the illness through the patient's eyes. Now, how challenging is that when you're dealing with patients that have had such dreadful experiences and have such diverse cultural backgrounds?
Well, you need time, and if you haven't got a shared language, you need an interpreter. So it's very important, I think, that people understand that you can only communicate so far with your body language and your eye contact and things like that. If you don't actually have a shared language, you absolutely need some sort of interpreting. And if you put that in place, then you will overcome a lot of the inherent health inequalities of that the person will have where they don't speak English. So that's the first thing, really. If they don't speak English, you have to have an interpreter. But beyond that, the important thing with cultural difference is that you mustn't assume that you know. You mustn't assume, for instance, if the person is opposite to you is a Muslim woman, that you know what she wants from her healthcare worker, that you know what she has been taught about her body, that if you assume, you'll be dangerous. You won't be addressing her needs. So you don't assume, you have to ask. It mostly takes time and just, time and just ask. Because assumptions are dangerous. And you have to try to overcome one's very natural tendency to sort of stereotype. Because we stereotype, but we do it automatically. That's how we function, really. We kind of think, well, here's a person, they look like this. They start to speak, I'm from Glasgow. Oh, well, she'll be a Protestant or a Catholic. She'll eat deep fried Mars bars. She'll, she's probably vote Labour. All these things, you can assume an awful lot about somebody and not even realise you're doing it. And really, one of the things that we try to teach the students when we're talking about diversity is leave your stereotypes and your assumptions as far as you can behind, but perhaps even more importantly, understand that without thinking, you will do it. So you do need to be self-aware and think about what might be working against your relationship with the person in front of you, that you're employing sort of automatically without thinking. Yeah, so self-knowledge is quite important when it comes to diversity, and then just interest in the person opposite.
Okay. I guess if, Jenny, as part of your job as a general practitioner, you would refer people on to other services, either to other physicians or to other social services or other healthcare services. So would you have experience, or how do you deal with maybe unfavourable attitudes towards this group of people, or what are the challenges in being maybe advocating on their behalf?
Well, there are two things here. There's the kind of just the human. I found really I didn't find a lot of overt prejudice in any other fellow professionals, because I suppose healthcare professionals, more than anybody else, have shown by their willingness to be working in that profession that they're kind of interested in people. So we didn't get any overt prejudice. What you did get was misunderstanding and ignorance. So especially for asylum seekers, people don't, in England, in Sheffield where I worked, people didn't necessarily know what asylum seekers were or what they were entitled to. So we would get phone calls to say, am I allowed to treat this person because they're an asylum seeker? And back then the answer was yes, and it changes. But so ignorance is a bigger problem with other healthcare professionals. But that's because, of course, they're a professional. If you sometimes over a cup of coffee or just chatting with somebody in a different environment out of work, you might discover there was more prejudice or more anti than you would expect. But that's that was very rare. However, when I told people, if people asked me who I didn't know in a social situation outside of healthcare, what I did, and I said, well, I'm a GP for asylum seekers, I was quite taken aback with some of the responses. But then that again is because, especially at the time, and I don't think it's changed much, people don't understand there's a difference between asylum seekers who are sort of seeking sanctuary compared to economic migrants who are seeking work. But I think, actually, I can be quite surprised about when there is a negative attitude to either of these people, because it's a human need to be looking after yourself and trying to fend for yourself and your family. So there's more anti people, I think, in the general population than you'd expect. And I think that's got worse since the crunch, because people are more materially uncomfortable and they are less tolerant, I think. Society's becoming less tolerant, is my perception. And it's because people are feeling materially uncomfortable. But also, actually, the tone from the government's not helpful.
Right.
And it does make a difference.
Okay. Just as kind of an adjunct to that question, I read many years ago when I was a very young doctor, a book called The Spirit Catches You and You Fall Down. And it's about this child who travels from Laos, from the Hmong people, to the States. She's got two very caring paediatricians to take care of her. She's an infant and she's got very caring parents. Now, there was a language barrier, but one of the issues was that the child was on anti-epileptic medication. There was side effects from that. There was pressure on the parents to use the traditional cultural remedies. And that's where the title of the book comes from, because that's how they describe epilepsy.
Yes.
Spirit catches you and fall down. So in your practice, if you meet that challenge or that dichotomy, how do you discover it first of all, and then maybe how do you go about managing it?
Well, I think that I'm afraid I've got no magic remedy to that, because you can be aware, you can ask, but when it comes to it, you don't know what people will do when they go home and how they will treat the medication. And I have to say that for all our lovely ethos and welcoming and holding of distressed in the Mulberry practice, we still practice Western medicine. And so people from Iran and Iraq, generally, that was part of their culture anyway. People from Zimbabwe. Eritrea, Ethiopia, I'm not so sure. But so you do your best, but in the end you're peddling Western medicine. And whether were people, how was medicine's adherence, how was compliance with what you were doing, I don't know. But people did come back. But I think that it depends on what you're medicating, you see. I mean, in the end, I would say one of the one of the great things about the job, and it's the great thing about medicine if you get to that level, is that there's an aspect of the person that it's the doctor's the healer, it's the nurse that was the healer, not the medicine, not what you were doing with them, not what you were prescribing, but the fact that you were there listening and sort of joining with them for that session. That was where the healing happens, I think. But we overlook that and we underestimate the power of it. We do that in medicine generally, is underestimate the power of sort of the relationship in healing. And which is a great shame because we over prescribe. But, well, yeah, we do. And I think that I did think when I was preparing for this, one of the sort of skills that you had to learn was to not deliver too much medicine. There was something else that you had to give. Yeah. But the other skill that you learnt, I think, was that, or the other thing that I got from it was this, the psychosocial impact of people's life, people's situation, how it impacts on their health. These things are indivisible. In my teaching with medical students now, this is the thing that I try and emphasise. You can't separate how a person feels from what happens to their body and their physical self. These things go hand in hand. And, you know, we talk glibly about medically unexplained symptoms. Well, they're only medically unexplained, but very often you can entirely account for them if you look at the social and emotional context of that person's life. And to be, I think, a proper practitioner, you have to understand how all these things impact on the person's pathology and how what they're feeling, what they're complaining, and how their illness is manifest. Certainly it has an impact on how they can deal with it. Yeah. I think I've strayed away from the question there.
That's okay.
Can't remember what you asked.
Okay. That's okay. I was just looking at the challenges between what we might prescribe Westernly and if there was some other practice within the culture that maybe people might feel or be pressurised into using. And how and they may have side effects or interactions with our own management plan, and how do we discover that, or are there easy ways to ask those questions, or how does one go about it?
Thank you very much. You brought me back on script. Actually, one of the very useful questions is, if you were back home, how do you think this would have been treated? I did learn. Right. I did learn to ask that one. So
that's
how
a good
do
question.
You think they'd have? Yes. How do you think it would have gone if you were back home? Sometimes you realise that there's something going on that you're not sure, you don't know what's happening because it's just not working. And I've got a beautiful example of that. But this wasn't a cultural thing. This was somebody's way of being. So I had a woman who, sort of against all our efforts, was just getting worse with things. And eventually, I think really I got very exasperated, I'm afraid, and a bit cross with her, and said, we've tried this, we've done this. She kept coming back. She did keep coming back, which was good. Cut a long story short, I discovered that whenever we came to an agreement about what to do, she would Skype her mum back home in Iran, and her mum would tell her what her doctor back home in Iran had said to her, and this woman managed to be on her mother's medication as well as anything else we were doing and giving her in the UK. And her mother's medication was a very strange combination of all kinds of things for hypothyroidism and for diabetes. So what I discovered was that this lassie was she was being sent from Iran all her mother's equivalent of medications and taking them as well as whatever we were. So at that point I stopped prescribing altogether and said, I'm sorry, but I don't know what I'm treating.
Yes.
And but that I don't think, that took weeks and weeks and weeks to understand that. position, and this was weeks of seeing somebody almost every week in terrible distress.
Yes.
And of course she was feeling pretty rubbish because she was eating all kinds of rubbish. And these powerful pills were having horrible adverse effects on her, and I had no idea that this was what was going on. So that was a lesson in something. I think perhaps I'd forgotten to ask the very simple question of what else are you taking? Yes. But I won't ever forget to do that again.
Yes, okay. 'Cause that mirrors quite accurately the story from The Spirit Catches You and Fall Down. They put the baby on traditional herbs. It had a very tragic outcome because the baby died. They took her off her anti-epileptic medication. And maybe if someone had asked that question at that time, how would you have done this back home? It may have unlocked the issue in relation to that. Just moving on from your practice in Mulberry, when you came out of there, was there any skill sets that you had learned that you could translate into and transfer across to your new practice, where much more conventional practice in that sense?
Well, I wish I could say. The reason I can't say is I didn't actually go back. The practice I then went into had a large ethnic minority Pakistani group, and actually I used the same skills, but in fact less well, because the way this practice dealt with their group was that they used family interpreters. Now the kind of the gold star of interpreting is not to use a family member, because you're compromising things, and sometimes you have to understand that you've got limitations to your consultation when you use a family member. So I went from Mulberry, where the interpreter was the gold standard, to this practice where family members were the kind of the norm. So you had to bear that in mind. But really, the thing essentially, when you're working with interpreters, there's a three-way dynamic, and that is very challenging. It's quite hard, isn't it, just in plain English to understand what's going on sometimes. So when you're doing it through another party, it can be even harder. So we have got some guidance for medical students that we use on how to work with interpreters. But essentially what I'm saying is communication is the key. And it's up to you to control the communication and to feel that it's going well. And if you feel that it's not going well, you're probably right that there's a mistake, there's a problem, and it's up to you to try to work out what that is. So if you're consulting with an interpreter, for instance, and you ask a simple question like, can you show me where the pain is? And 5 minutes later the answer hasn't come back to you, you sort of know that you're not being faithfully interpreted, and you have to take control of that. But so when you're using interpreters, there's a few skills. Think about what you want to know, ask simple questions, and if you get nonsense back, ask again. But how does it translate? Communication skills, really. It's communication, that's the key. And listening.
Just in terms of if you watch the news these days about the deluge of refugees from Africa and asylum seekers into continental Europe, and even aside from that, the demographic changes that are taking place globally. So our new graduates have to face an increasingly diverse world, and now the medical councils are putting a requirement on us to ensure competency at the point of graduation, not to learn it after you've graduated. So I know you could maybe write a textbook on this, but what would be what are the key things that our students should know or should be informed about in terms of, we'll call it cultural competency, in terms of when they graduate? Because they can't know it all. So what do we need to focus on?
Well, I think really you need to focus on generic doctoring skills, and the communication skills are key with this. and also learning how to use an interpreter so you know when it's going wrong apart from anything else. So communication skills are key, but I think one of the things about culture and diversity is that you mustn't be scared that it's a huge thing you have to learn. Because, for instance, doctors, they don't often train in their own city. I'm from Glasgow, I trained in London. Automatically I was an alien. Doctors tend to be alien. Mm-hmm. Now, so you can use your own experience of your own life to understand what it is, how it is to be slightly outside of things, and what the advantages are when you're sort of a bit objective. You're not completely of the culture that you're in, so you're having to learn how they do things. You're having to learn what the idioms of speech are. It applies actually when you relocate across your country.
Yes.
As much as it can apply to people from other countries. The other thing is that the evidence is actually that we have more trouble. If I was to sit down and talk to a doctor from Zimbabwe, I would have more in common with that doctor from Zimbabwe than if I was to sit down and talk to somebody, say, who was a welder from Sheffield. Right. Because actually, and we don't talk about this much, there's much more difference, diversity or cultural difference actually in class than there is perhaps across cultures. So an educated person from another culture, you will have a lot in common. If you've been to university, you've got a lot in common. More in common perhaps than somebody who left school at 14 and has been working away in your own city or your own where you're from. So that, I think, that's quite a bit of information that people don't know. You give people that and they think, oh, okay then, it's not a great mystery. What actually you have to be is interested in people, interested in the stories, allow them to talk their narrative, listen and process what they're saying. And that's a generic doctor skill. That's not to say that you don't get cultural difference, you do. But I think that it's true to say that our society, say Sheffield, certainly London and Glasgow, big cities, and Cork, they're becoming more multicultural, and without even thinking about it, we're managing diversity all the time. You know, if you think about how different English can be in different languages, it's still English, but it's expressed differently. You know, English spoken by somebody from India sounds different from English spoken from somebody from Zimbabwe and from Glasgow. You know, English spoken from Aberdeen sounds very different from English from Glasgow, and it's still English, but it's expressed differently. We're sort of dealing with diversity all the time, and so there's no mystery, but you have to be open-minded and interested. I think as part of preparation for this, I had to think about this particularly. One of the, you know, we can perhaps harbour more prejudice against people, our own people, than perhaps people from abroad. You know, if you meet a Syrian refugee, chances are you're going to have a fair amount of empathy for them. You meet a homegrown drug addict, and you might not have any empathy for that person. So, you know, you have to just be self-aware about where your prejudices lie. Scots and English haven't traditionally got on. You know, sort of, that's funny. It's funny, but actually, I know there are some people, I open my mouth, I forget I sound like I'm from Glasgow, and you can see, they think, oh yeah, you sound like Billy Connolly, and I don't like that accent. So it's sort of, there's all kinds of ways we can act in prejudice towards each other. It doesn't necessarily need to be that you're from abroad. And I do think that we can reserve our harshest judgments and prejudices for our own people sometimes. So the other thing I'd like to get onto is the stereotyping thing, because one of the things about medical practice is, the potential for the stereotyped, you're a doctor, so you're like this. You're a nurse, so you'll act and think like this. You're a social worker, so you'll act and think like this. They're all very sort of, within the medical hierarchy. There's strong stereotypes held. I think you have to work against them quite consciously in your practice, let alone sort of when you're talking about people from other cultures. So, diversity is the management of difference is something that we're doing all the time. Yeah.
Okay. It's interesting you mentioned the biases you might have within people, groups within your own culture. But if I could pin you down to a clinical situation of pain relief. Now, by and large, most doctors should be interested in, and we can relieve patients' pain quite easily. But I recall reading papers from the United States about the perception among doctors that Afro-Americans tolerated pain much better than white people, so they got less pain relief. And that was documented. So how do we inform our students about these things? Because we tend to say, if you're dealing with this clinical situation, always remember such a point because it's important in the management or the diagnosis or the differential diagnosis. So these are very specific areas. So what do we do, or do we just list them out for them, or how do we manage to get this across to them?
Pat, that's a stinky question.
Sorry about that.
Well, because I think it's impossible to be completely informed, isn't it? And that's a very interesting example of how you can't always get it right.
Yes.
So what I would hope is that in our modern medical training, you're teaching people, teaching people to use all that they've been taught, but nevertheless to always look at what they're seeing, and if it's not fitting with what they've been taught, to ask themselves questions. Why is this different? Why is this not working? So you'd have hoped, wouldn't you, that you've got a person in pain and you've given them a little bit of pain relief, but they still seem to be in pain. You would hope that they would just get more pain relief.
Yes.
But so I think that it's always and actually that's the job of the doctor, isn't it? Always. You're sort of trained to apply a huge amount of knowledge and to know an awful lot, but you're also trained to think outside the box, or further than the box, or greater than your training, because you have to remain sort of self-critical, but also critical of the situation. You've always got to use your intelligence and your imagination and apply it to what you're seeing, because that's the job. The job doesn't fit always the algorithms and the descriptions, because we haven't yet got evidence-based medicine for absolutely everything. And I don't think perhaps we ever will reach that. So it's that's a difficult one, because you're talking about where human experience is different from, where the evidence isn't, and where it's not necessarily at your fingertips, and you're having to apply your intelligence and you're learning to question what you're seeing.
Yes.
And to take you beyond your learning. That doesn't make sense, does it?
Well, it does too.
Well, yeah, I don't know. I think this is quite difficult, because I'm not sure. We want certainty.
Yes.
We have to be practitioners who can apply the facts when we know them and they're fit, but also deal with uncertainty and unfamiliarity and be comfortable with that. Be comfortable with the feeling that you get from that, and yet still be effective. And that's quite difficult. That's quite difficult to deal with. I would say GPs, that's the realm we're in, is dealing with uncertainty. We kind of perhaps we can manage that better than most. For medical students, if you're going to take it right to the beginning of undergraduate, I think that's very, very difficult for them, because you can't learn uncertainty. You want to learn facts. You want to know that if you if you've got this set of symptoms, it's this diagnosis, and then this is the treatment. That's what medical students want to know.
Yes.
And I think it's a bit, perhaps, I don't know, we'll have to see about this. Can we teach them that actually you've got this and this going on, and there's these possibilities, and you make your kind of your judgment in conjunction with the patient and come to the best sort of fit as a remedy, and that's as good as you'll get. And that is so far from black and white. It's so far from this there for this that I'm not sure whether you can teach that at an undergraduate level or whether that's just unfair.
Yes. Yes.
Do you see?
Because that was my next question, was how might we prepare and inform medical students for this diversity?
Kind of thing.
Yes.
I know. Well, I think that I think you can be honest about it. That it's like you have regular verbs and irregular verbs in French, and here are the regular verbs that you learn, and here are all the rules about regular verbs. But the reality is there are far many more irregular verbs than regular verbs.
Yes.
And medicine's exactly like that. You still have to have the basics, but I think we have to be honest about medicine not being black and white. But for learning, I'm not sure how useful that is. So I haven't answered your question, because that's the question I ask myself in education. I think it's quite difficult. I'm not sure that you can. It's fair to teach people who don't know anything at all.
Yes.
Multimorbidity and polypharmacy before they've learnt the single strands.
Yes.
But what you have to emphasise is that it's not that simple. And that does need to be emphasised from early on, I think, because otherwise people do prefer black and white, and they don't like being uncomfortable. And actually we're needing to produce practitioners who can be comfortable with being uncomfortable.
Yes.
Or the state of, or it's just a different way of being. Because actually, one of the things is, with uncertainty, you might be uncertain, but you still have to make a decision. You have to come to a reasonable, reasoned decision. So I haven't answered your question, because I think that's a difficult one.
Right.
But this is the nature of medicine now, isn't it?
Mm.
Yeah. And I guess that the students will pick it up from being more exposed to patients and more exposed to real practice.
Yes. When we talk about patient-centred care, how do we get our students to hear the voices of these people, as opposed to hearing it from their tutor or their trainee?
Well, that's a good question. Number one, you have to have patients in medical education.
Yes.
They absolutely need to be in there.
Mm.
And it's harder to do that than you'd think, but we're all beginning to do it much more. In Sheffield, where I work, we've got students are now about 10, 12 times having 3-hour sessions 12 times in their first year with patients to talk to in a general practice setting. This is a new thing. We only did it last year, and it was very, very popular. But that's the first time that they had any real contact with patients in Sheffield in the first 2 years of their medical education. So you can go down 2 years of medical education traditionally and not see sight nor sound of a patient.
Yes.
So putting the patient into education, I think, is vital. I think the other thing that's happened without us really being on top of it, but we're waking up to it now, is that medicine changed, but medical education didn't change. And what happened with medicine changed, and the patient is no longer in the hospital. The patient is out in the community and all over the place, but they're not in the hospital. But we are training medical students in hospitals. So they've got to be out. They've got to go where the patient is.
Yes.
And that's where the education will be. And that's where they will understand. That's where they're applying the application of the stuff that they know. That's where they'll learn that. It's the only way to do it in a real situation.
Okay, Jenny, I'd like to take you back to when you worked at Mulberry. And you had a clearly enthusiastic, well-motivated and a very strong setup there to deal with these issues in terms of this type of diversity. But what advice would you give to the doctor who's in the accident and emergency department, or indeed in a general practice, who's not set up for this, and a patient presents to them and presents them a challenging situation? Is there 4 or 5 key points you would say to do or not to do when you're dealing with such a situation?
Well, the first thing is you have to let go of your timetable.
Yes.
Because whenever these situations always take time, and we were lucky in Mulberry, we had interpreters and we also had longer appointment times.
Yes.
Actually, but that's why Mulberry was set up, was because the GPs who were coping with the influx of immigrants couldn't manage within their normal surgeries this kind of influx of patients. So luckily, I mean, hopefully, as a GP, you've only got one per surgery.
Yes.
And you just have to let go of your appointment time and understand that it will take you longer. Because if you're dealing with somebody who's got whose English isn't their first language and you're having to use an interpreting service, it will take you twice as long. So that was the first thing. I think everything takes longer, so that's quite difficult. The other thing is that if you're using a telephone interpreting service, then you do, it adds a complication in that you miss out on body language and you miss out on certain cues that you can pick up in an interpreting situation. So it just makes it difficult. And I would say you just have to spend time until you feel that you know what's going on and you know that you're practicing safely. And that is necessary, whatever situation you're in. It's the same in A&E. Yes. If you don't, unless it's a sort of life or death situation, you're needing to talk with somebody and understand what they're trying to convey. And that means using interpreting services however you can find them. And in these situations, the family member, if they're there, if they can speak reasonably enough English, that's good.
Right.
But, you have to remember even interpreters don't necessarily speak good English.
Yes.
They just speak better English than the patient. So it's always to do with using your clinical acumen as well as your interest. You have to be accepting, you have to use your clinical acumen, you have to use all the skills actually of your doctoring, all the skills of your training have to be brought to bear for any patient, but in particular for patients where there's can be potential for misunderstanding.
Yes.
So, but it's there's no magic thing. I know from my experience that when our patients turned up in A&E, they were just a nuisance.
Yes.
Because people couldn't, they didn't want to spend the time with them, but they had to. You have to give them time.
Yes.
Because you can't sort them out without time. But of course, time sort of in an A&E department is kind of, it's a premium, at a premium. So, our patients used to turn up in A&E and be there for hours.
Yes.
Because it would take hours to deal with them. Yeah. So there's, I'm afraid there's no, you just have to do what's in front of you. Manage that.
I suppose that's a good bit of advice for a young doctor who comes across this for the first time, is to think of getting an interpreter. Because it may not be the first thing that might pop into your head when you're in that situation.
No, that's right. And actually you have to establish if you need one quite early on.
Yes. Because
people can very easily pretend that they understand what you're saying.
Yes.
It's because, we're all of us very socially skilled. And when you go to a new culture, you pick up very quickly what a smile does, whether this is yes or no, and you automatically mirror what people are saying. So the smiling patient who's always saying yes can easily not understand a word, and you can waste your time for 10-15 minutes thinking that they're understanding everything. And then you ask a crucial question and you realise they've understood nothing.
Yes.
So establish that from the beginning and you will save yourself time.
Right.
Yeah.
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 And I'm just thinking about the young doctor, and you might give some of your own insights into this, because as doctors, we tend to like to be in control of the situation, of the diagnostic situation, to know what to do and what's going to happen next, and how to manage anything that moves off compass or off the pathway. But if you added to that the linguistic problems and the cultural problems, and things taking much longer to get sorted out, and maybe something happening that was not intended to happen but happened because of this, then this must cause significant emotional distress, because we do get distressed when things go wrong with our patients. So did you ever experience that? And if you did, how did you deal with it?
Well, and I don't know if this... The patient I talked about before, who I had been trying to help for many months, and eventually I realised that her mother's doctor was treating her as well as me. She, until I understood what was going on, that was a very difficult situation, because this was a very needy person coming back again and again, asking for help because she felt so awful. And every week you're trying something different, and every week you're, not necessarily medication, but every week you're trying to try a different tack, think, what have we got, let's start from the beginning, go through this, what is it we're missing? I mean, the last thing I would have thought of was that she was eating her mother's medication as well as her own.
Yes.
But it did take me a long time to, for some reason, uncover that. I don't know whether it's because eventually she felt so bad that she told me the truth. But that's the other thing. I think, we're only human. We do trust our patients when you ask them a question to tell you the truth, as far as they can.
Yes.
And that doesn't always happen. So, this is a difficult thing, because I'm now going to talk about human instinct. By the time you've gotten to the end of medical school, you will have clinical acumen, and you will have an instinct beginning to develop for people's truth-telling, but also for people's how they are, physically how they are. That, thank goodness, comes in quite quickly. You walk into a cubicle in A&E, and by the time you're an intern or first-year doctor, you will know whether that person is an extremist or not.
Yes.
That's kind of important.
It is.
So that, always go on that. Always go on your professional assessment, which will kick in very quickly, which is schooled in you, so that when you get to be an intern, you can discern an ill person from a walking wounded. That's very important.
Yes.
And that's very, very important when people can't speak English. And obviously, if they can't speak English and you've got somebody who's in a terrible state, you don't find an interpreter. You kick in with your emergency medicine, and you ask all the questions later, because you've had to save their life first. So it's this sort of thing, but you learn that. And I'm a bit, you learn that. So what's helpful, always helpful, is your training. Because your training won't abandon you just because somebody's not speaking English.
Yes.
Your training will help you to assess what's needed.
Okay.
And that's your job. What is needed here?
So what happened to the lady after you found out about her digesting her mum's tablets?
Well, eventually she was on hardly any medicine at all. She decided to stop all her medicines, her mother's medicines as well as the ones had been giving her. And eventually she felt a lot better. Still had a lot of emotional and difficult issues, but they were at least unclouded by the myriad medical interactions of all the medication she was taking that were making her feel really rubbish. So she felt better, really, for giving up all the tablets. And that's another lesson we always have to learn, is tablets can make people ill. Multiple tablets can give them multiple problems. Yeah.
Yeah.
No, she had. She would have wondered whether you were going to be cross with her, Jenny, or not.
Yeah.
Did it in any way affect or deteriorate the doctor-patient relationship
Okay.
as well? Because that, I guess, is something that we're always very concerned about.
All right. Is that a rather hard question to ask, Jenny? In terms of, we said you're a bad doctor, you let it deteriorate.
I was a bad doctor to that patient.
Okay.
No, you weren't, because you found it out, and because it continued. You were a very good doctor.
Okay.
But
Okay. I'll ask the
was there a
question.
change in the interaction?
Okay.
Yeah.
So, Jenny, with that patient, there clearly was a trust issue between you and that patient. So, did that have a knock-on effect for your future interaction as doctor and patient, or as patient and doctor?
Yes. Well, the first thing is, and give her credit, she kept coming. She did keep coming. But ultimately, she decided that she didn't need medicine and she didn't need doctors. And, I think she was right. For her to really function again as a person in her new environment, she had to start to look to her future and build her future. And her future wasn't going to be sitting with a doctor talking over her problems. So that was the beginning of the end of our relationship, if you like. But that was a good thing for her. It was a good thing for her. But we sort of we never got back the rapport that we had, but then the rapport we had before was built on a false understanding. And once we reached a shared new understanding, she didn't need me anymore, and that was good.
Right.
So yeah. So everything changed for the better for her, and I sort of was a bit wiser. Yeah.
Okay, so that kind of leads me on to thinking about mental health in terms of cultural competencies and how you might meet those challenges, because they're challenging anyway.
Yeah.
And you mentioned getting the truth from patients, and while if you have severe chest pain, you have an investment in telling the doctor the truth about your pain.
Yes.
That may not always be the same with mental illness. It may not be, or the patient may not perceive it to be in their best interest to disclose information. So,
no, that's absolutely right. And I think one of the things that people assume is that I worked for 10 years hearing the details of harrowing stories. Actually, that's not kind of how it was. I allowed people to disclose their stories if they wanted to, but you didn't need to hear the story to know that you had a distressed person in front of you, and you had to let them decide who to disclose to and when to disclose. And that wasn't necessarily appropriate in the 15-20 minutes we had in the surgery. So, when I perceived that somebody had to have, well, that's the other thing, one of the important things of a practitioner is to know when it's not your job and to pass the patient on to the person whose job it is. So we had a counsellor in the practice, or several counsellors, and it was their job to be doing the therapy. It was our job really to manage the medical symptoms that people were getting. And this is where the job was very interesting, because what I learnt absolutely from that was this thing about psychological distress and physical illness being so interlinked until you can't distinguish what started and what was the cause and effect. So one of the things that I feel we have to teach properly is that what happens to people, their social context, their emotional milieu, is not separate from their medical presentation. These things are absolutely entwined, and you have to, in order to practice good medicine, patient-centred care, you have to attend to all these things. Now, your expertise isn't in all these things, but if you're unaware of a person's circumstances and emotional background and what they're bringing to the table in those terms, then you're not going to practice good medicine, because you're going to be giving them stuff that's inappropriate for their situation. The other thing I learnt was that chronic anxiety is much diagnosed. I think that a lot of people, especially these days, are anxious. And I ask students to imagine that feeling that you get when you're just sitting, you're about to sit an exam, and you've got that feeling in your stomach, and you're feeling a bit all keyed up, and your heart's going like this, and you're a bit sweaty in your palms, and you don't know if you can write properly. Now just imagine if you feel like that all the time, every day, and on top of that, you've slept 3 or 4 hours a night. How many days or weeks or months would it take you to feel quite unwell? Now, all my patients, that was their daily reality. Asylum seekers, every day, they are waiting for a letter that says that they can stay, that means that they are safe for 5 years. That's what the letter brings. It brings safety. Without that letter, they have no idea where they're going to be. So every day they have this anxiety working away. And I can tell you, it makes people feel really ill, and it gives them proper physical symptoms, not just imagined physical symptoms, proper physical illness. Chronic undersleeping, terrible stomach problems, headaches, palpitations, all these things. So one of the things is, don't underestimate anxiety and its effect on the autonomic nervous system. That can give people quite profound and unpleasant symptoms and illness. Yeah. Now what you do about that's difficult. But if you don't realise it's even there, then you're going to be going off down blind alleys. And the other thing you'll do if you're not careful is investigation after investigation after investigation. Yes. When the answer lies simply in the story.
Yes.